Thank you. You know, when I'm listening to everyone, I just feel so proud to be involved with this program. I think when I reach this stage of my career, I thought, you know, I know most of the things, and I never thought that I'm going to learn something new. And I think all of us, Sean, not Mr. Drug Policy, he's definitely Mr. Kroucamp, because without Sean, definitely we would have battled. And I think Professor Hugo would agree. We really would have battled. So thank you, Sean, very much for that. And it's, to me, amazing. It's been an amazing journey. It's been amazing what we learn. And all of us feel that way. It is life-changing. Just the way I see people begging in the streets. You never know. You think you know, but you don't know what the real stories are. So it was a life-changing event for me to be involved with this. You recognize the gentleman on this MMC. This is with our Outreachville team. I'm talking about a journey. This is indeed be a journey. I think in terms of complexity, I've been involved with projects and programs across Africa, multi-country projects, and this is truly, if not the most complex and most difficult and most challenging, but also the most satisfying program or project that I've been involved in. It's not one project, it's more a program with a lot of sub-projects underneath it. And I also want to thank MMC, Mr. Nkoko, and the city of Tshwane. It is amazing. We are true partners. You are true partners. It's not a funder only and leaving others to us. We make the decisions together. We determine priorities and we change together, which is fantastic. The journey, I'm going to start with where are we now. It's now about 2 years, and we have established 18 service delivery sites. Now, service delivery sites, it's not full days, all of them, about 10, 11 is full day, but the most is satellite sites, so it's where we deliver a service. But we're also more and more expanding, delivering services at spots that we're not even counting here. The needs are just so great. I'll come back to that. There are 7 regions within the city of Tshwane. We try to expand and to reach as many as possible people everywhere. We have to date enrolled more than 4,000 clients. They've received direct assistance from COSAP. More than 34,000 clinical and counseling sessions have been attended. We, of course, our community of people who use drugs, very important to us. We established about 38. Initiated an OST, and we've barely started about maybe just about more than a year ago with OST. We're already on 892. That was end of August, these statistics. Dr. Bora will expand more on the OST part. More than 60% of our clients returned for a second visit to the site. It is significant if you know the whole history of how we started. So many of our we started with very little services. I'll get back to that one as well. We basically started delivering a service. We had to deliver, look at our deliver on KPIs. Peers, an incredible, valuable asset to the, and I see them, David and Schlatzi, an incredibly valuable resource within our project. We didn't initially incorporate them, have them in the teams. They are our contact with our clients. More than 50 clinical associates, social worker, nurses, doctors, and community health workers are employed and or trained within the COSAP site, building experience that none of us had in substance use field. When we started interviewing people, we couldn't find anyone that really had. There were some people that had some exposure, especially our social workers, had some exposure in the field of social work. And then a wonderful achievement, only been done with the city of Tshwane. We actually started with NSP as well within the project. Where did we start? So it was a long, tricky journey to get to this point, and we're very, very, very far from perfect. We're continuously learning. In May 2016, UP and City of Tshwane signed the service level agreement, a 3-year agreement. By August, we received our initial funding, and of course, without the funding, we couldn't employ or recruit any personnel. We couldn't start any of the processes. Now, the very first challenge was balancing, and it continued to be a challenge, balancing expectations. The needs are so great. Balancing the initial expectations of to deliver immediately on KPIs. So the city has to deliver, everybody involved with the project has to deliver. But of course, and then versus the realities of implementing a project or process to get it to the stage of initiating services. We had to start from zero base. We didn't have staff, we didn't have materials, we were busy developing it. The recruitment through the University of Pretoria takes about, any university, any bureaucratic system will take about 3-4 months just to appoint people. So we had to balance. In the one side, we had to start treating clients, the needs are just so great, but the other side, we had to ensure that we implement a quality service. So we couldn't be perfect, we couldn't identify perfect sites. So what did we do? So the 1st November, we clients enrolled. So initially we enrolled a sort of a parallel process. We looked at quick wins for initially. We identified partners, especially in the inner city, and you've heard MMC referring to our existing partners, SADPW, Vanessa and Dr. Elaine. Thank you so they were existing partners of the University of Pretoria. We were in partnership, they're delivering primary healthcare services. They're very much familiar with the inner city issues, homelessness, and the substance users has actually been going there for primary healthcare services. And then out, so Derby now also, and it was fantastic that we could immediately establish, and of course, Step Up, the harm reduction services was already at out, so we could immediately go in and offer a comprehensive package. We brought the staff, we brought the clinical skills, we could offer that side, and out and Step Up had established relationship with the Department of Health, with HIV/AIDS testing, and there's a drop-in center. So that was sort of a perfect setup for us to start initiating, to start enrolling clients for our program. And then we also have a primary healthcare clinic, Daswood Clinic, that we also started. Now, and then of course in parallel, so this was what we've seen as our quick win, but also perfect partners. I think it was an ideal situation. I think what's very, very interesting about COSAP is that none of our sites are the same. They're rural areas, their needs are different, the priorities are different, and of course we have the same services and guiding principles that we apply everywhere, but the needs of the communities are not, the populations aren't the same. We have more homeless, very often immigrant population within the central city, and then in the rural areas we have more people often already have their homes. So the approaches, and I think especially if our social workers might in the panel discussion answer some questions, but they're different, and the way you manage them is also very different. So in parallel, while we could start with the services, of course we had to do a very quick recruitment. We used existing staff in family medicine, existing clinical associates while we were recruiting other personnel. Everybody just jumped in and started with a project. And in parallel, we went the normal process of implementing a project, which is longer. So the continuous stakeholder engagement, site identification in priority areas. Of course, the needs. Now, engagement and communication, Sasha has spoken about that. He's already referred on how we work. Very critical not to start and to do our own thing. We cannot do this project on our own. We work in partnership, and I think you can hear just from the talks that we had here, it's amazing. Everybody is working together. Sadiba Hope, we mentioned Hope Line with David and his team, the referral system, all the MPOs that's funded by the City of Tshwane and not funded by City of Tshwane. They all have services that they offer within a community. We had to ensure it's cooperative, it's collaborative. We cannot do this on our own. It's impossible. The needs are incredible out there. Now, it's a struggle, and it's also very satisfying. Partnerships, especially with also in terms of skills training, we refer for skills training. Sorry. Okay. And then, of course, challenges. So we do consult extensively, but this consultation cannot stop. It has to be continuously. The training and working with ward-based outreach team, with community health workers, with NPOs, continue. Because you have different people coming in. There are, of course, different agendas. That will always be a headache. Expectations from MPOs in terms of funding. COSAP receives funding, so everybody wants funding, but we offer training. Sasha has also elaborated on that. Now, establishing the sites and their treatment points, again, you've heard it earlier in the talks, is that we initially, this is a learning in progress. As I said, it's not perfect. If we had 2-3 years to plan it and to do all the groundwork, fantastic, but we didn't. We had to start running. And not crawling or walking, but we had to start running with the implementation. We haven't specifically budgeted for ground zero or green sites development for COSAP sites. We trusted and we assumed that it will be easily be integrated within the healthcare system. That has challenges and that have been very challenging, and I'm sure Professor Hugo will talk more about that, into the primary healthcare system. Because as we do not want, we have different sites, types of sites. You have standalone sites where you deliver the comprehensive service, and then you have integrated sites, which of course is the ideal. At the moment, as far as possible, we refer most of our services that we cannot do ourselves, like your HIV testing, like to enable to sort of a comprehensive harm reduction package. We do refer to local clinics, but the cooperation is not always that easy. Again, our ground people, which we have a couple of here, might also elaborate more on that. So this was not easy. We have established sites, but we needed clinics. We had negotiated. It feels as if we've been negotiating forever, myself and Prof. Hugo, with governments, with departments of health, with clinics, with local clinics, and there's always been a buffer. There also everybody is concerned about security, about stigma, but we're treating with methadone. Aren't there going to be more thefts? So that was a major concern from our partners. They say, no, they're very much for the program, or is it going to take some of their resources away? They haven't got time to do their other services. And very much for the service, but just not close to them or in the clinic. And also budgetary constraint from the clinic side. So in the end, we had to settle for what we could get. Not ideal. Going forward, we'll definitely focus on that, but we'll look at that. So household component, we started what Sean referred to, the ward-based outreach team. That's our ideal model. For various reasons, within the city of Tshwane, our wards didn't work. They will start working now again, so we couldn't fully utilize that component, which would be that link with the households. Our staff do go out to households, but that support from starting in the household and identifying that, it's limited support. And I'm sure Prof. Hugo will expand a bit about that as well. Clinically, Dr. Bora will elaborate on that. Okay. Skills development, last slide. The skills development, also a challenge. At the moment, we do refer. Our initial indicator, I think many indicators were very, or targets or deliverables were very idealistic, again, built on what we hoped for and not really knowing anything about a project like this, a substance use project, and not having any experience. We thought everybody will go for skills training. It doesn't work like that, as we've learned, as complete novices. They need to be functional. We started the project with not having OST. We didn't have NSP, we didn't have drop-in centers. So we had this, we had the community, we had the social workers, we had our clinical staff. Ongoing challenges, as I said there. And then employment, the expectation that people, they are now treated, they're on OST, they do get a skill, which often isn't relevant. What we see is that they often have skills, and we need to maybe create more entrepreneurship initiatives, which would be great. And then, yeah, so that is something we're working on. More and more people are being on skills development. Okay, now the whole process, we are basically focusing. So we started there. I think we're very proud of what we have achieved. We are learning the whole time. I think what is important is the flexibility in this process. The flexibility and continuous program learning is extremely valuable. And the flexibility that the City of Tshwane also allowed us within this project. And we would discuss, there are often reviews, and we would discuss, we would reallocate budget. As I said, we started off trusting that our OST will be budgeted by our district health services. Unfortunately, didn't realize. And we requested from the city, can we have limited funding reallocated to OST? We started off with 50 clients and 6 months limit, which of course we realized also is not always that practical. But in negotiations, they allowed, I think about July last year, we started on a full OST program. And again, a lot of challenges, but very learning. So the focus is on ensuring coverage. We continuously, I keep on saying about the need. The need is so incredible that our staff is working, they would identify, there's requests from everyone, but there's a group there that needs help. There's a high concentration of users there. Now, obviously, we didn't start with a normal mapping process, like if you do have the time to do that. But we know where the high priority areas are, where the injectors are, also based on work. And I think Harmless is also currently busy with mapping, Davi, and in certain areas, Sashangui. So this regular continuous process with regular reviews of progress against targets and adjusting strategies as required. As we get new data in, new approaches, environmental changes, and budget reallocations which of course makes this a very difficult program to manage. Nothing was cast in stone in the we continuously have to adapt, and we have to change and reallocate. Now, going forward, I've referred to the OST inclusion. NSP has been a series, as with OST, which I think it was very advanced for the City of Tshwane to allow us to incorporate OST in a public health system. NSP, we recently started also at the sites providing NSP. We're working on drop-in centers, and then ultimately we would like to provide the comprehensive package of harm reduction services, but ideally integrated within the primary healthcare service. And then, as I said, not the ideal setting. We're working with the basics in our sites, and the city, again, has allowed us some funding to upgrade our facilities, which include the mobile clinic. Just a couple of photos, then I'm finished. Okay, now, our teams, our people. Now, I always say that no program can succeed without the people. No program can succeed without passionate, committed people. And this program requires that. I'm absolutely amazed by the people that work with us in this program. Mostly young people, and they've gained so much experience and knowledge, but I can call them any time of day or night. They're always there. They have a WhatsApp group, and I always see them weekends, evenings, sharing the joys and sharing the sad events of their clients. They rejoice, they share their activities. They work very independently at the sites where they are. They're innovative. They go and they don't wait for management to say, you have to do this, you have to do that, you have to do that. They just go ahead. And I have to give tribute to them. They're absolutely amazing. And what we also realized, that absolute passion of theirs and their commitment and being so involved with a very complex group of people, and they give them all their love. It's amazing. And they definitely need, and what we say is debriefing sessions. requirement. We often, as often as they need to, on an individual and as a group basis, they get debriefing sessions from a psychologist. So that is available. Just going through this. The little greenhouses there, we've got Benolo here, our clinical associate, who actually identify this as a NGO partnership. I love it, but there are definitely things that we need to work on there. And then that one is a bit hidden, Benolo. They go out in the streets on Friday where they have outreach days. Now, outreach is a major event for them because they have to go out. They're not sitting at the sites on their own. And then these are just photographs of our inner city site staff that went to Soshanguve because they see clients there that come from Soshanguve or come from other areas, and they went there to visit with their partners or their teammates in Soshanguve, the houses of the parents of the clients that they see in the inner city. I'm just going to show. These are all our teams, very excited, getting involved, treating the clients, car wash days, painting houses, going out to schools. Schools becoming more and more a need and a demand. They often link with schools, and teachers refer, although that wasn't a target group of us, teachers refer them to the schools, to the Kroucamp site as well. All right. Again, sessions with the clients, training sessions, outreach, children. Voila. Thank you. Thank you.